speaker. Dave?
How's everything going today?
Wonderful.
Hey, thank you for everything. Hey, hello everybody. It's a real pleasure to have you guys here today. I know I say this a lot, but I really have the great pleasure of introducing today somebody who is truly a dear friend and a dear, dear colleague. I remember being in the ICU when I was training, and one of the things that really impressed me, being in the ICU, the patients were so sick, they were so complex, and they had so many medical problems. And you felt at times really alone in the pressures of having to make decisions that sometimes you felt were over your head. And I remember how good I felt in the ICU when we used to round, because when we rounded with a whole team of individuals. We rounded with our nurses, we rounded with the other doctors, but something that was very unique to me at that time is we rounded with our pharmacist. What an amazing idea, I thought at the time, where we had a pharmacist that if I knew I wanted an antibiotic, but this patient had liver disease or renal disease, it was so much I had to pick from, which antibiotic, what dose. It was so great that I could turn to my pharmacist and say, hey, what do you think? And that sounds good to me. Now write it and prescribe it, and I'll sign it, And it really worked out great. And not only did we have somebody who would tell us what's the best drug, but also what was the right doses. They would monitor for us. They would do everything. And that's why when I came to A.G. Holly and we came up with the concept of the team approach, specifically with our really complex patients, we realized very early on that we needed a top-notch pharmacist. But I have to be honest with you, like when you go to pharmacy school, you don't go to pharmacy school to become a TB pharmacist, But we were really blessed. We were lucky enough that in the Palm Beach Health Department at the time, there was this pharmacist who they kept calling Jerry Jean. And I had never met Jerry Jean. But then one day we were having problems at A.G. Holly, and Jerry Jean came in as one of our consultants. And I remember sitting in a room in our superintendent's office and looking at her saying, I want her. I want her to be part of our team, And we were lucky enough that Jerry was insane enough to join us.
That's true.
And that was about, 13, 14 years ago, right, Jerry? And I can honestly tell you that Jerry Jean is, if not one of the most important parts of our team. And the reason is, with our patients and their complexities, you've heard the statement, it takes a village. It literally takes a village to take care of some of our patients. And one of the great things about having Jerry as part of our team is whenever we're running into a rut, we're getting into problems, I turn to Jerry Jean and say, what would Jerry do? And Jerry always comes up with the right answers. And that's what today's program is supposed to be all about, which is now we're going to bring Jerry Jean to you. One of the things we're going to be seeing is in situations where you're getting into that problem and different problems we face, Jerry's going to review today some of those issues and how to approach it. But what I'm hoping for most is in the future, if you're running into one of those problems and you need Jerry Jean, you'll now know who to call, or hopefully you'll call. So without further ado, it is my great pleasure to introduce Dr. Jean Stambaugh, who's our pharmacist here in A.G. Holly. Jerry, thank you very, very much.
Thank you. Thank you for that great introduction. I wish all of it were true, but thank you anyway. So this is going to be part 2, why TB drugs fail. And I've sort of given it a it's not working, guys, sort of giving it a subtitle here. Karen, it's not moving. There, okay. So I've given it a subheading of how we fail TB drugs. Because a lot of times it's not the TB drug that's failing, it's how we use that TB drug. And therefore, if we fail the TB drugs, we're also failing our TB patients. Now, you could consider our patients to be one of 3 groups. And since this is the middle of football season, I'm going to use a football analogy here. You've got those patients that play for the Florida Gators or Alabama Crimson Tide or maybe Texas Longhorns. Stop laughing at me. And those teams can do, in a game, 6 or 7 penalties, maybe a couple turnovers, maybe a couple fumbles, and on any given day, they're probably going to win that game. So those are patients that come to us that are basically healthy, you have everything on their side, and whatever we do, they're probably going to get well. Maybe even if we do nothing, they're going to get well. Then we have a second larger group of teams, which I'm going to call, I'll be nice, David, the Sunshine State Commoners. And that's a team that could probably make 2 or 3 penalties and maybe 1 fumble or 1 interception, and on most days are still going to win that game. Then we have the third group of teams, which we're going to call Moonshine University losers. And that team, the individuals on it, if they make a single mistake, they're not going to win that game. If they fumble, if they have a penalty, if they have an interception, they're not going to make it through that game. The only way they're going to win that game is if the other team is playing blindfolded. So that's our loser group. And I don't know about your practice, but the patients I see seems to call, not in that first group, they're not on the Gator football team. They may be a commoner, or more and more they're becoming the losers. So it becomes increasingly important that we look at the little things, the details, that make a difference in how we treat our patients. So there are a lot of problems we can run into when we're trying to treat a patient and get them through 6 or 9 months of therapy. They can fail to respond. TB meningitis can be a complication. Renal failure, hepatitis, can't swallow the pills. How often have you heard that? GI intolerance. They can swallow the pills, but they don't always stay down. Adverse drug reactions can be a main reason why patients don't complete therapy. Allergies can be an issue, and also drug interactions. So we're going to address many of these issues. So here's our case study. JB is a 42-year-old black male who was admitted to the hospital following a new onset seizure. He complains of persistent headaches over the past month and a history of 30-pound weight loss and a chronic cough. He is diabetic and has a history of alcoholism. He has a negative PPD, but an abnormal chest X-ray and his AFB-positive sputum, smears, and culture. He is started on 4 drug therapy and referred to his county health department. JB does well, and his smear and culture negative at 2 months. If the Ambutal and PCA are stopped, he's continued on 2 drug therapy. However, at 3 months, he is again losing weight, his headaches have returned, and he is now smear and culture positive. So why is this patient failing? The most reasons for JB's failure are noncompliance, resistance, low sodium drug levels, or inadequate tissue penetration. So if you will place your votes now. Very good. Low serum drug levels are winning the race so far. Resistance is a close second. Oh no, serum levels are getting ahead again. Nobody thinks this patient is non-compliant? My goodness. Okay. So we got most of you with low serum drug levels and a few of you with resistance, and it's mattering of noncompliance because I urged you to do that, but inadequate tissue penetration. So let's look at our patient. The patient has diabetes, so already he has 1 strike against him. Because of diabetes, he probably has reduced immunity. He probably, if he's uncontrolled, has changes in GI emptying and absorption of drugs. We don't know all of the effects of severe hyperglycemia, but we know we can have altered protein binding. We know that we can have renal disease because of that. We can have vision problems because of it. TB and TB drugs can make diabetes more difficult to control. So we also already have an issue right there looking at his TB drugs. And some of the anti-diabetic drugs can contribute to hepatitis. He also has a history of alcoholism. So alcoholics frequently have gastritis. That means they're probably going to have less absorption of the drugs, and they're probably going to have less GI tolerance for the medications. We know alcohol can affect metabolism of itself and other drugs. That could change our drug levels. Alcoholics frequently have malnutrition. Again, can be an issue. Decreased immunity. And, of course, an increased risk of side effects, particularly hepatitis and peripheral neuropathy, and are at high risk for noncompliance. So what are our other options here? We mentioned thick wall cavity. Well, here's a thick wall cavity. Here's the patient who has a very thick-walled cavity. Whoops. See if I can do this. I can't do that. So we got a patient here that has on one side 2 thick wall cavities and on the other another thick wall cavity. Problem is, can we get the drugs through that thick wall and into that cavity? Because we know that we've got thousands of millions of organisms in that cavity. Now, we could do surgery. We could remove a thick wall cavity. But in this case, he's got disease on both sides. And we certainly can't take out both of his lungs, so surgery may not be an option here. But this would be a patient where a thick wall cavity may cause us problems in treating this patient. So JB has an MRI, and his CNS TB has gotten worse. Which of the following drugs would not be a good choice to cross the blood-brain barrier in therapeutic quantities? So he's now on INH and rifampin. And we're going to add back, because he's failing, we're adding back ethambutol and PGA, and we're also looking at 2 additional drugs. So of these listed, which drugs would you not want to depend on for treating CNS TB? Most of you are saying ethambutol, a few for PGA. Oh, no, you changed your mind in PGA. Streptomycin, INH. Remember, this is not a good choice. Okay, so it looks like we got about 55% of the answers are saying ethambutol, 63% are saying that ethambutol would not be a good choice of drugs. So let's look at our choices. It's going to depend. What type of CNS TB does this patient have? Do they have TB meningitis, like this patient, where the meninges are inflamed? We know that when we have inflamed meninges, that drugs penetrate that blood-brain barrier to a higher degree than when we don't have inflamed meninges. So if we've got this patient, we're going to do pretty well with more drugs than we are if we have this patient. This patient has a tuberculoma. You can see it, the arrow here going to the area. But there is no inflamed meninges in this patient. So although we need to get our drugs in to treat that tuberculoma, we cannot depend upon the concentrations that we would expect if we had meningitis. So we're going to get lower concentrations of our drugs in this patient. So how are we going to look at this? How do we know that we have enough of our drugs? So here is a simple chart. And what I've done is I've listed the common drugs, and I've given the expected peak concentration of these drugs in the serum given at common daily doses. So this would be an INH dose of 300 milligrams a day or a rifampin dose of 600 milligrams a day. And over in the far column on the right, I have at least one of the published ranges of susceptible MICs in micrograms per milliliter for our drug. So INH, we would expect a 300 milligram dose, a peak concentration in the serum of 3 to 5 micrograms per milliliter, and we have a minimum inhibitory concentration of 0.01 to 0.25. Okay, it looks fine because we want to be 4 to 16 times our MIC. But what are some of the issues with this simple chart? If you were depending upon this to select your drug and your doses. Well, in the first place, we're looking at peak concentration in the serum. But we don't often treat TB in the serum. TB is usually in an organ. It's in the lungs, it's in the brain, it's in the kidneys, it's somewhere else. It's usually not in the blood. If it is, we're in really big trouble. The other issue here is we're talking about expected concentrations. So we gave INH at 300 milligrams to 100 normal individuals. We expect to see a serum concentration of between 3 and 5 micrograms per milliliter. But our patients are not normal patients. They are individual patients. And they have issues going on that could change what they actually get. So although we may expect to see a concentration of 3 to 5, we may see a much lower concentration because they have diabetes, they have other drugs that interfere with the INH and lower its concentration. So we may not see that expected value. And this is the concentration in the blood. So we're going to have at some point figure out what the concentration is somewhere else. Now we know from studies that for the most part, rifamycin, for example, reach much higher concentrations in the lung, typically 6 to 10 times the serum concentration. So that's a very good thing. The information about how much drugs gets into the CNS is an entirely different story. There's not any huge stories. Patients tend not to want to volunteer to have pieces of their brain removed for analysis or to have a spinal tap done or a tube put in there for 24 hours so we can do a complete analysis. So we have very sparse information on concentrations in the CNS. Now the other issue here is our MIC. The MIC is minimal inhibitory concentration. It's the lowest dose that we need to inhibit the growth of the organism. It's not the cytal dose. It's not the dose that's going to kill the organism. It's an inhibitory. It's a static dose. And we really want to kill these organisms, so we don't want to just stop their growth. Because if we're using static doses or concentrations, then we're depending on the patient's own immune system to finish off the mycobacterium. So if our patients had good immune systems and could do that, they probably wouldn't have developed active TB to start out with. And our patient here is diabetic and he's alcoholic, so already he has 2 strikes against him there. So we would like to see minimal bacterial cycle. The other issue with this is that we usually don't get MICs. We send a specimen off to the lab, and what do you guys in the lab send us? We're stuck with this thing called critical concentrations. So instead of doing like you would for strep or pneumococcus, where you just do a series of different concentrations for each drug, we don't do that. We have specific concentrations that we look at. So if we have a patient who's on a drug and the MIC, well, not the MIC, but we send it to the lab and they come back with a result that says resistant at 1, but sensitive at 5. Means they only tested it at 1 and 5. We don't know whether that true MIC of that patient is 1.5 or 2, or if it's 4. So how high do I need to be? How much concentration do I actually have to have in order to treat this infection specifically? So you guys out there in the labs, we need to get you all to do us some real MICs so we have a good guidepost here. So we got another issue when we're looking at drugs and doses. It's called protein binding. Most drugs, when they're in the serum, they are bound to proteins, usually albumin. And when they're bound to that, they're not working. A protein-bound drug is not doing anything to kill the mycobacterium. It's only the free drug that's effective. So if we looked at ethambutol, for instance, 10 to 15% of that concentration that we're measuring in the blood. And when we get those concentrations back from Chuck's lab, that's total concentration. That's both bound and unbound drug. But the only part of the drug that's working is the unbound. So for instance, ethambutol has 10 to 15% protein binding. So that means that out of that concentration that lab gave us, only about 85% of that dose is actually working. Look at rifampin. Rifampin is 84 to 90% protein bound. So that means that only about 10 to 15% of that concentration we're showing in the serum is actually killing the mycobacterium. So it's something we need to know about our drugs when we're looking at those simple little charts that tell us what the MIC and what the serum concentrations are. Well, it doesn't get any easier. So our patient has CNS TB, and we haven't differentiated the type at this point. But if you look at this slide on CNS penetration, and, you know, folks, I'm not going to argue anybody about whether these concentrations are correct because we don't have a lot of real good evidence on this. But INH is usually considered to be 90 to 100% CNS penetration, which means that your serum concentration and your CSF concentration should be about the same. So INH would be an excellent choice of a drug to treat CNS TB, whether it's a tuberculoma or whether it is a meningitis. because even with uninflamed meninges, the figure on the left in this column, 90% penetration, and with inflamed, 100%. So if it works in the blood at that concentration, it should be working in the brain. Rifampin, though. Rifampin is only 10 to 25% penetration. Now, this is of concurrent serum levels. So only 10 to 25% of that rifampin concentration is actually getting into the brain. Cyclosamine, 80 to 90% CNS penetration. Again, an excellent drug to use, but streptomycin is less than 10, so that might not be a great choice. So the figures on the left here, the 90 to 10 to 75, are the CNS penetration in percentage in normal brain, no inflammation. And the ones on the right, you see much higher. CCA goes 75 to 100, and ethambutol from 10 to 50 is much higher and inflamed. So while patients were on ethambutol and he has inflamed meninges, ethambutol is going to be a good choice. But if it's a tuberculoma without inflammation, it's not a great choice. But this is also not as simple as it appears. Of course, nothing ever is, right? Whoops, I just went by the slide. Protein binding. Okay. So let's look at this slide. And I know it's kind of a busy slide. The white columns are the drug statistics in serum. So you have expected serum concentrations in micrograms per milliliter of 3 to 5 for INH. The number in parentheses is just a simple number in the middle somewhere that I picked out that was easy to do the math computations on. We know that it's 10 to 15% protein bound, which means that 85% to 90% of the INH is going to be effective in killing the mycobacterium. So that gives us an effective concentration in the serum of 3.4 if we had a reported lab at 4. So not too bad. We know in the green column here, the dark green, that in normal CSF, we had 90 to 100% concentrations. The thing here is that all of the drug in the CSF is unbound. So the total drug in the CSF is active drug. It's effective drug, unlike in the serum where it's a mix of bound and unbound. So in that dark green column, 100% of the CSF in normal gives us effective concentration of 4. That's higher than the effective concentration in the blood. Now if we go over to the next set of columns, the lighter green, that gives us the figures for inflamed meninges. So again, for INH, 100% penetration and effective CSF concentration of 4. Look at rifampin, however. Rifampin, expected serum concentration of 8 to 24, and I picked 10 as my example here because it was an easy number to work with, 85% protein bound. So what does that mean? We only have 1.5 micrograms of effective rifampin in the blood to fight the TB. Now, CSF crossover in normal is only about 10%, which means that our effective concentration in the brain, of normal brain, is only 1. Not very high. As inflamed, we can go up to 20 to 25%, which gives us an effective concentration there of 2, which is actually higher than the 1.5 that is effective in the serum. Now, the final column over here is MICs as they were published in 1993 by ASM. And they say for rifampin, the MIC is 0.5. So at 1 or 2, we are 1 to 4 times the concentration that we would need. If we're looking at 4 to 16 as our desired range, it's right on the very bottom of that. But it's still more than we have in the blood as far as effective concentration. Now, if we did everything right, we finally came up with the right drug, then we might end up with a CAT scan of a smiling brain like this one, because they're happy because we came up with the correct solution of what drugs and what doses to use in our patient. So another choice we gave you was low serum drug levels. So why could we have low serum drug levels? Well, obviously, if we gave the wrong dose. Now, most dosing of TB drugs by people who work in the TB field is the right dose. Where I see the wrong doses, it's more likely to be with ethambutol because so many physicians and practitioners are afraid of the optic side effects of ethambutol. So of all of them, that's what is most likely to be underdosed. We can also have reduced absorption. Now, our patient has diabetes, so that could lead to malabsorption. HIV patients can also have lower absorption. Could have had GI disease, part of the stomach or the gut removed. Could have malnutrition. It could be laxative abuse, which we run into, in patients who have eating disorders. Could be drug-food interactions or drug-drug interactions, and we're going to look at many of those in just a minute. We can also have increased metabolism of our drugs. The patient could be vomiting. So they're throwing up the drugs. They're not sticking around in the stomach long enough to get absorbed. Or, obviously, noncompliance. The patient's simply not taking the drugs on a regular basis. So if we looked at the gut, down here at the bottom you see all these little papillae. And because there's so many of those, the gut is just simply loaded with them. Gives us a large surface area for our drugs to be absorbed from. So we get maximum absorption through this area. But if our patient is seriously malnourished, then one of the first things that go is the papillae. We have fewer of those, so we have a smaller area of absorption for the drug. Talking about patients who have low serum protein levels, maybe 1, maybe lower, which we occasionally see, they may not have enough surface area to absorb adequate concentrations of the drug. So that can be a concern if our patient is malnourished. In that case, what you're going to need to do, you may need to initially give the drugs IV rather than orally, since they can't absorb them. Now, the next barrier here is P-glycoproteins. And in each of those little papillae are things called P-glycoproteins, whose job it is to keep poisons from getting into our body. So they pump all the things that are in our gut to get absorbed through that cell back out into the gut. Well, how many of these we have is genetically determined. Some of us have a lot, some of us don't have very many. If we have a lot, we are more likely to have lower drug concentrations because it's pumping all the drug back out to the gut and it's not getting absorbed. If you don't have as many, you will have higher drug concentrations. Now, to make things more complicated, the P-glycoproteins can be either increased or decreased by giving different foods or different drugs. Grapefruit juice is something that's commonly given to increase the concentration of certain drugs, such as cyclosporin, in patients because it inhibits the P-glycoproteins. It allows for greater absorption. Our next big barrier is our CYP450 enzyme system, responsible for metabolizing most of our drugs. And again, how much we have of each of these different families of enzymes is genetically determined. So one person may have a lot of 3A4, and the next patient may not have as many. If you have a lot of 3A4, you may metabolize the drug much more rapidly, so you're going to have lower relative drug concentrations. Again, how much the activity of these enzymes can be either induced or inhibited by a number of different drugs, including our TB drugs. So that's something we need to keep in mind as well. Whoops, I missed one here. So here's your next question. Which of the following drugs can be taken without regard to meals? Moxie, still ahead. INH is gaining. Moxie's going up. Ethambutol is in the race. Nobody's choosing rifampin. Good choices here, guys. Okay, so still going. All right, so I'd say at this point, moxifloxacin is the winner. So are we right? Just to give an example of how significant it can be, we talk about something called bioavailability. And bioavailability is the percent of the drug that actually gets in systemic serum concentrations throughout the body compared to what it would be if we gave that drug IV directly into the vein. And for rifampin, if we give it on an empty stomach, and you guys are all right, nobody selected rifampin, we give it fasting, we have 100% bioavailability. So the same amount of drug gets into the bloodstream, whether we give it IV or if we give the same dose orally. But if we gave that rifampin to a patient who just ate a good meal, that bioavailability goes down to 70%. So just by giving rifampin with food, we have lost 30% of the activity of our rifampin. So which drugs do we need to be worried about, and what things can cause that type of an interaction? So food drug and drug-drug interactions are often caused by things like divalent ions, iron, calcium, magnesium, aluminum, zinc, but also things in foods like fats, whether or not the pH of the stomach is high or low, and how much protein was in that. And the drugs that we use that are most affected are INH, ethambutol, and rifampin. And then the quinolones, ofloxacin and ciprofloxacin. We need to think not only in terms of food, did they eat a meal, but we need to think in terms of fluids. Because I know a lot of our TB programs use incentives to get our patients to complete therapy. And sometimes they just give them a coupon to go to McDonald's, but sometimes they take out a can of Ensure or Boost. And, of course, what is the inclination is to take the pills and wash it down with Ensure the Boost. But remember that Ensure and Boost are meals. So they have protein, they have calcium, they have other minerals, they have fat in them. So that's the same thing as if they had eaten a meal with that drug. So you don't want to use those. Dairy products, things like milk, can also cause complexes to form, and you get reduced absorption. Things like orange juice and apple juice, and I know that there's no nurse out there that can live without apple juice to give drugs with, also contains calcium and iron. The good thing here is that we're usually using small volumes. So although it's going to have impact, unless our patient is really down there in the bottom of that loser team, they're probably going to do all right anyway. But we've got something else that we don't normally think about, and I see mistakes made here quite a bit, and that's our patients who are on tube feedings. Because remember, tube feedings have that fat protein and all those minerals and everything. So we need to stop those tube feedings 2 hours before we give our TB drugs and keep it stopped for 2 hours after. So you need a 4-hour window in there in order to give your TB drugs. If you give it while those tube feedings are running, you're going to bind up the drug and you're not going to get adequate concentrations. So what drugs do we need to take on an empty stomach? And we define that as 1 hour before or 2 hours after a meal. Those are going to be INH, rifampin, rifabutin, ethambutol, so you guys were right, PCA, and most of the quinolones. Now there are some that we can take with food. And the reason we say take it with food is that it usually causes upset stomachs when we take these drugs. So to decrease the GI side effects, we can give ethionamide or PAS with food, but we need to keep in mind that it may still lower the drug concentration slightly. Clofazimine, on the other hand, lamprene, is good to give with food because it actually increases the absorption of the clofazimine. So get maximum absorption, you would want to give clofazimine with food. So there are drugs that we don't have to worry about. PCA is one, cycloserine, rifapentine, and yes, you were right, moxifloxacin can be taken without regards to meals. So by this time, you're probably feeling like my cat Dusty, and we're going to change here to something else. Let's talk about something else that could be wrong in treating our patient. He has resistance, and that was a popular choice when we gave question number 1. Now, you could have had primary mixed resistance. So we had the patient, we did a sputum, it came back as sensitive, but maybe he has a compartment in his body where he has another strain. And this might occur in a situation where there's a lot of TB being transmitted. Typically not in the United States, but in many countries of the world where TB is very prevalent, they could have been exposed to multiple strains of TB. And when we did our sensitivities, we only hit one of those. More likely would be a secondary resistance. And there are a number of factors for secondary resistance. Patient noncompliance is obviously at the top of the list. Improper prescription. We didn't prescribe the right doses, take into consideration other drugs the patient was on. Inadequate tissue penetration, that thick wall cavity. So we maybe only get a little bit of drug in there, enough to cause resistance, but not enough to kill the organism. Or they have an unusually heavy burden of disease where we need to use more drugs because we have more bugs. So what is the resistance potential of our drugs? Now, if you look at this normal curve, on the y-axis, we had the probability of resistance developing, and on the x-axis, we have increasing potency of our agent against mycobacterium. So over on the left, if we gave a drug that had absolutely no activity against TB, let's say we gave them furosemide, Lasix, a diuretic, to treat their TB, it's not going to cause resistance because it has no effect at all on the population. If we give a drug that's a super drug, really extremely effective against TB, then we get the maximum effect, and we're not going to get resistance because we killed the organism so completely and so rapidly that there was not time for resistance to develop. It's the drugs that are in the middle that are the problem. Those drugs that may be static, aren't cidal, those drugs that just put enough pressure on the organism to change the dynamics of the population. So where are our TB drugs in this continuum? Well, we know that they're effective against TB, so they're not down on the left corner there. But however, we know that resistance develops with our drugs. If we give one drug, if we give INH by itself, we give rifampin, our two best drugs, by itself, we're going to get resistance. That means they're in the middle here. We're still looking for that super TB drug that's going to kill all those bugs at one time, and we don't need to worry about resistance. We don't have it yet with our population. Hopefully, in the laboratory somewhere, it's being developed, but we don't have it today. That's why we need to give more than one drug at a time. Now, we looked at the population. Don't you love normal curves? Hey, so useful. If you look at the population of mycobacterium in the body, it's going to look like a normal curve. And some of them are going to be very sensitive to our drug. So even at a relatively low dose, low serum concentration, those bugs are going to get killed. Some of them are going to require a very high dose because they're very resistant to our drugs. But most of them are somewhere in the middle. So if we give one of our middle-of-the-road drugs, it may kill off half of this population. We kill off all the ones that are sensitive. And what we're left with are those organisms that are more resistant to form a new normal curve further out to the right. So here's our next question. Shortly after his MRI, JB's lab work shows rapidly deteriorating renal function. His creatinine clearance is currently 20 milliliters per minute. Which drug may need to have its dose modified? INH, rifampin, ethambutol, or PCA? Ooh, PCA is winning here. Rifampin's in the race. Okay. So I should have told you that we had started our patient, we started failing, we started back on all 4 drugs, and we added the other 2 drugs in there. So he is currently on these 4 drugs plus additional ones. Okay, so it looks like PCA is the drug that we're going to have to dose modify. Ethambutol's jumped up a little bit. Somebody said INH. Rifampin's still growing. Okay. All right, so let's look at what we need to do in renal conditions. So what drugs need to be modified when we have a patient with severe renal failure? We need to modify those drugs that are excreted renally as active drugs, as active metabolites, or as potentially toxic metabolites. And how do we adjust the dose? We have 2 choices. We can either reduce the size of the dose, go from 1,200 milligrams to 800 milligrams, or we can extend the dosing interval. drugs that are concentration-dependent killing, such as the aminoglycosides and the quinolones, it's probably better to extend the dosing interval rather than to reduce the dose size. In other drugs, reducing the dose size is fine. When do we need to look at adjusting? Most drugs, we need to think about whether or not we need to adjust them when creatinine clearance reaches 50, 30, or 10 milliliters per minute, and a few very cranky drugs at 80 milliliters per minute. Whoops, this way. So let's look at our TB drugs. INH. Now we need to keep in mind that some of our TB drugs can also cause acute renal failure. INH can cause renal failure, but usually it's only an extreme overdose. This is not something you're likely to run into unless one of our patients decides to take an entire bottle of INH tablets. And we normally do not need to adjust the dosage in renal failure till we get down below 10. And at below 10, it really becomes academic because at that point they're probably going to go on dialysis, and we're going to look at something, a different method of dosing. Rifampin can cause acute renal failure. It's probably idiosyncratic. It occurs. It can occur rapidly. We need to be able to think about that when we see a patient with sudden onset renal failure and patients on TB meds. But again, if the patient's has rifampin on board, they have decreasing renal failure, we usually don't need to adjust the dosage, and we are looking at dialysis by the time that we need to do that. So, aminoglycosides. Obviously, here's a drug that's both toxic and it's excreted renally. We're going to have to start worrying about these drugs at about 80 milliliters per minute. We're going to adjust the dosage. Probably better to extend dosing intervals. Instead of getting it daily, give it twice a week at the same dose. Capreomycin I've included in aminoglycosides, although it's a polypeptide and not aminoglycoside. Sort of keep it in the same part of your brain because it works just like the aminoglycosides. Ethambutol, renally excreted as an active drug. So ethambutol is a dose that we need to look at adjusting the dose here. And we need to start thinking about it at 50 milliliters per minute. So this would be a drug, ethambutol, that we need to reduce the dose on in our patients. What about the quinolones? Well, ofloxacin and levofloxacin are both renally excreted. We need to reduce the dose, starting thinking about it at least, about 50 milliliters per minute. And we can do this again because it is concentration dependent to maybe increasing the interval, giving it 3 times a week instead of daily, for instance. Moxifloxacin, on the other hand, is a quinolone that is partially excreted as an active drug, is partially metabolized. And the recommendation from the manufacturer is that no dosage adjustment is needed in renal failure, which means Moxi would be a good choice of quinolone in our patient because he has decreasing renal function. We still need to get those concentrations into it. Cycloserine is renally excreted. We need to be concerned about it starting at 80 milliliters per minute. So to summarize that, renal failure, what you would want to do is try to use drugs that are metabolized by the liver, such as INH, rifampin, and PCA, that you do not need to modify the dose until they get down below 10 milliliters per minute. You might want to consider using moxifloxacin as your quinolone instead of levofloxacin or ofloxacin. You want to give lower doses of the drugs that are renally excreted. You could give the same dose less frequently, or you could give it in a lower dose. If the patient is on dialysis, then give the dose after dialysis because many of these drugs are at least partially removed in dialysis. So let's look at our patient. JP is successfully treated with steroids with contrast-related renal failure. 3 weeks later, he developed elevated AST and ALT at greater than 5 times the upper limit of normal. And his total bilirubin is at 4 and increasing. So, typical loser patient. As fast as you can get your fingers on one problem they're having, they develop another problem. I know that none of you have patients like this. So, what do you do in hepatic dysfunction? Typically, you would stop the drugs and allow the patient's liver to cool off. Try using renally excreted drugs such as ethambutol, quinolones, and aminoglycoside or Caprio. Once the liver is cooled off, your enzymes are down, start adding the suspect drugs one at a time. Typically because you have the patient on INH, rifampin, and PZA, all of which can cause hepatic dysfunction, you need to get some of those back on board if you're going to keep a short-term 6-month regimen. So start adding them back one at a time, carefully monitoring the patient to find out which one is suspect. Typically, if you have an isolated bilirubin increase, rifampin is more likely to be the drug that you're going to be concerned about, but you can't depend on that. You might want to consider using rifabutin instead of rifampin. It still allows you to do the 6-month short course, and it has about 1/3 of the toxicity on the liver that rifampin has. So in these patients, it could be a good alternative. Try giving these liver toxic drugs twice weekly instead of daily so that the liver has a chance to recover in between. You might want to consider using levo or ofloxacin in this case and moxie, because although moxie's effect on the liver is very minimal, for our looser patients, all it takes is a minimal difference to tip them over. Consider using adjunct agents. Acetol, although it's usually for gallbladder, does seem to help at least with the symptoms in some of the patients. If they have hepatitis B or C, you may need to treat that. Even if you're not trying to cure the patient, treat it to get the inflammation in the liver down so that you can continue a TB treatment. And you need to monitor these patients very closely. So let's change gears again, once again here. Whoops, uh-oh. All right.
Right-click on the slide. Sorry. Right-click, and then push next slide. Okay?
Okay. Yeah, the arrows aren't working. So, problems in treating TB. We still haven't gotten this patient through. So we need to look at some of the issues here. Failure to respond, obviously he has. TB meningitis we've addressed, renal failure, and hepatitis. So let's look at our next big category, noncompliance. There could be a lot of reasons for noncompliance, far more than I can enumerate if I used all the slides here to do that. Psychiatric issues can certainly be a big player. You may need to get the involvement of mental health practitioners into treating their psychiatric issues and or their substance abuse before you get the patient through treatment. Can't swallow pills, GI intolerance, these other things we're going to talk about at this point. Now, one of the ways we try to overcome noncompliance is to do DOT. We go out and give the patient the drug, give it to them, observe them taking the medication, so directly absorb therapy. We saw them take it, we know they got the drug, right? So we don't have to worry about noncompliance because they're not taking their medications. But the question is it DOT or is it DOD? Instead of directly observed therapy, are we giving directly observed delivery? If I go out to the house and give them the medication, watch them take it, I did therapy. If I leave it for the weekend, dose for the weekend, or the kid's still in school, they're not home taking medication, I leave it with mom to give it, that was delivery. That was not directly observed therapy. But sometimes when you're doing directly observed therapy, you're going out there, you're watching them take the medication, it turns out to be directly observed delivery. You give them the medication, you talk to them for a minute, you leave. They go in the bathroom and throw it up. Well, we delivered it to the patient. We watched them take it, but we didn't deliver the drugs to the bloodstream. It didn't get there. That was delivery. And I know you can't spend all day with each of your patients, but you've got to be suspicious of them doing something like this and never swear that your patients are taking their meds. We have had patients here in the hospital where we always do DOT, but we have had the patient on a PEG tube. We couldn't rely on them to take it orally, so we put a PEG tube. So we're giving the drug directly into the stomach or the gut. It's got to be directly observed therapy, right? I mean, they got to have gotten the drug. They walk over to the sink to brush their teeth, lean against the sink, and push on the PEG and push out the pills. We've caught patients doing that. We had a patient here a number of years ago who was a nurse, And, of course, like doctors, nurses are very bad patients because they know all the tricks. So this patient is MDR. We put her on IV therapy because we can't get her well. We've got her on IVs. She's getting that drug. It's going into her vein. We've got somebody sitting next to her bed the whole time the IV is running, so we know that she's getting that drug. Except the patient's in bed, the aide is sitting right next to her, she's reading a book, she reaches over, pulls out the IV and puts it in the trash can next to her. We did our best to give her directly observed therapy, but we didn't succeed. So never, ever believe that you got a patient who is totally compliant. There is no such thing as a totally compliant patient. If they want to get around you, they can do it. So what are some of the issues? Well, maybe they're non-compliant because they're having trouble swallowing the pills. And I know that you all have heard this a lot. So you can try crushing the pills or using an oral liquid. Now, INH is available as a liquid. The problem with INH liquid is that it's 50 milligrams per milliliter. So you end up giving, for a 300 milligram dose, you end up giving 30 milliliters. That's a whole ounce. Now, which wouldn't be all that bad, except that it's in sorbitol. So you're giving INH in 30 milliliters of a laxative. They're going to get diarrhea. If you have them on 900 milligrams twice a week, you're giving them 3 ounces of this stuff. You're not going to have a compliant patient for very long. Rifampin is not available commercially as a liquid. The manufacturer provides a formula in the package to mix it with simple syrup. Problem again is it's not a very concentrated solution. So you end up giving another 60 milliliters of rifampin in simple syrup added to your 30 to 90 milliliters of INH, and you've got a whole glass full that you're expecting the patient to drink. Not likely to be compliant. So you could try crushing it. You could put a little bit of jam, honey, applesauce, but don't put it in that and then walk away for 2 hours and come back and give the medication because it's not going to be very stable in that. So you need to crush it, mix it, and give it immediately. PCA and Sabutal, again, are not available as commercially as liquids. You can make up things in simple syrup or other solvents, or again, you could crush it or put it in jelly or applesauce. And yes, I know jelly and applesauce are considered foods, but you're getting very small quantities here. So, what about GI intolerance? Well, they swallowed the pills, they got it down, but could they keep it down? Well, you could try starting out giving it in divided doses, giving a little bit here, an hour or two later, give another dose. You really don't want to do that very long, so you want to consolidate that down over a period of a few days. You could start with a low dose and increase the dose over several days. Again, you don't want to run this very long because you're risking the chance of resistance developing. You can get after meals. Well, we know that meals will lower the concentrations of our drugs, so you may need to monitor that patient, or at least have a high suspicion if they are not responding that you may have inadequate drug levels. You can medicate the patient. You can use an H2 antagonist, something like Zantac or Pepsid. I would recommend you do not use Tagamet and Metadine because that does have activity on the CYP450 system and it can lower drug levels. You could give proton pump inhibitors, something like Prilosec or Prevacid. We've had good luck with metoclopramide. You can give either 5 or 10 milligrams to the patient, give it to them 30 minutes before you're going to give them the TB drug. It's antiemetic, and it will increase the rate of which the drug goes through the GI system. So it's a very effective agent. Usually you can use that alone and it will solve your problem. Sometimes you have to use other adjuncts, something like promethazine, Phenergan, can be effective, given again 30 minutes or so before the TB meds. In desperate cases, you can go to the really expensive things like Zofran, but sometimes a little bit of lorazepam will also do the trick because patients, just like our cancer patients undergoing chemotherapy can develop an anxiety related to their medications. If they take the medications 2 or 3 times and they throw up, they are going to know that they're going to throw up the next time they take the medications and may not be willing to do it. In fact, they might start gagging as soon as they see the pills in your hand to give it to you. So if that's occurring, you can give them something like 0.5 milligrams or 1 milligram lorazepam, again, about half an hour before the meds, and will help them get over that anxiety and will get them through that. All else fails, you could go to something like a PEG tube, where you're putting the tube directly into the stomach and bypassing the gag reflex and the GI issues related to that. So PEG tubes are a definite consideration for patients who have GI intolerance, and I think you should probably have a relatively low tolerance for that. So what else could go wrong? Can't swallow. Guys, I'm missing a bunch of slides. No, they're missing. So what else can we do? We've got can't swallow. We can do a PEG tube. We can also do IV. We can put in an IV, and in that case, we're bypassing the GI tract entirely. And this is a really good option for those patients who come in severely malnourished and can't absorb the drugs anyway. INH is available as an injectable. It can be given IM or IV. You're probably not going to want to give it IM because you're going to have to give 3 milliliters of that IM for every dose, 300 milligram dose you're going to give. So patients aren't going to like to see you coming through the door if you're doing that. You can put that dose in 100 milliliters of either normal saline or D5W and give it over a half hour to an hour, and the patients tolerate it very well. I know that's not always practical in a home setting. Rifampin is available as an injectable, but you can only give it IV because it's very irritating. It's also a mess to work with, but again, in 100 milliliters of normal saline or D5 and given over 30 to 60 minutes. Obviously, the quinolones and aminoglycosides are available as injectables, so those are options. Now, I know out there, and I hate to bring this up, because I know that North Carolina, for instance, South Carolina, have had the drugs made up into suppositories and given the drugs as rectal suppositories. My concern about that is you may not have consistent absorption of the drug from the rectum. So we're not sure how much they're getting. You would certainly want to use something like drug levels in order to make sure that you're getting the right dose in the patient. So what about other adverse reactions? Well, we can sometimes overcome them by giving them at bedtime. That way the patient oversleeps, sleeps through the medication. Side effects. You wake up in the morning and they've already gotten through them. I know that's not practical in the field. You certainly are not going to want to go out and give every patient a dose at bedtime. Not practical. So you may have to switch to a different drug. Worst comes to worst, switch to a different drug. But there are some other things we can do. If the patient has allergies or itching, we can try using antihistamines. Something like diphenhydramine or something like hydroxyzine given 30 minutes before the TB medication will often take care of the issue. Sometimes you may have to give additional doses, like at bedtime, to carry the patient through. If it gets worse, you might consider steroids, although that's usually not necessary. And in some cases, you may want to do desensitizations. Well, see, David, they're out of order. So what else is likely to occur in our patients as an adverse reaction? Yeah.
I'll help you out. You take care of this.
Okay. So high uric acid levels. We know that PGA and ethambutol both can cause high serum uric acid levels. Well, there are things we can do to lower that to help prevent gout or renal problems. Allopurinol, Cyboprim, is a good choice. But remember, it has hepatic toxicity, so you would want to keep that in mind if you chose to use that. Sometimes you can add colchicine to that, 0.6 milligrams, given 1 to 3 times a day, and that will take care of the issue as well. So Benacin is an old-time drug that we've used for a long time and is also effective. Myalgias and arthralgias, all of our patients get that. I don't think if the patient's taking the medications, they're going to get myalgias and arthralgias. One thing to do is to encourage them to get up and move. The more they sit, first thing in the morning, it's going to be a lot worse than it is late in the day. You can also give NSAIDs, things like ibuprofen, naproxen, that will help relieve those symptoms and get the patient through. So if the patient had allergies, we could do a desensitization. And under desensitization, what we do is we take very, very low doses of the drug and gradually increase the dose and the length of time between the doses. So for instance, if I was going to do a rifampin desensitization where I want a 600 milligram daily dose, I might start out with first dose in the morning at 0.1 milligram. 15 minutes later, I get 0.2 milligrams. Half hour later, I might get 5 milligrams. And then during the day, I gradually increase the size of the dose and the interval between the doses. Usually within 1 to 3 days, I can consolidate those doses down to a 600 milligram dose once a day. You really don't want to do desensitizations in a patient with severe allergies unless you're in a facility where you can monitor the patient and you have emergency treatment available. We do it, we put the patient in a room, we have the crash cart outside the door, and we have a nurse in that room every 15 minutes checking on the patient. The thing to keep in mind once you desensitize the patient is that you can't interrupt therapy. If you have to stop that drug for any reason during their therapy, you may have to go back and desensitize that patient all over again. But it's certainly an option to get patients through. Okay, what about drug interactions? There are some major ones out there. Phenytoin, dilantin, is a major interaction. So if we got a patient on rifampin, we know that that will lower the levels of phenytoin. If we have them on INH, it will increase the levels of phenytoin. So which side wins? Well, we need to do dilantin levels to determine. But the effect of our drugs on dilantin can be significant. And let me give you an example of a true story from a number of years ago. This is back when we were just beginning to find about mechanisms for drug interactions. And I was working as a consultant to the county's nursing home. We had a patient come in who had had a series of small strokes. And as a result of that, his wife was no longer able to take care of him at home, but he could get up and walk around the facility, and for the most part, he was okay. Well, when he came in, of course, we did a PPD. It was positive. So they started him on INH. Now, as a result of his series of little strokes, he had developed a seizure disorder for which he was taking dilantin. It was well controlled. About a week after he came into the facility, all of a sudden he had slurred speech, couldn't feed himself, he was staggering gait. And what did we think? We thought he'd had another in a series of these small strokes. And gee, isn't it bad? He's probably going to have several of these until he finally has the big one. Too bad, but there's not much we can do about that. Well, I happened to go to a pharmacy seminar in Orlando that weekend. And what did they talk about? They talked about this newly discovered interaction between INH and dilantin. So I went back to the facility on Monday saying, I think we need to do a dilantin level. And a normal dilantin level should be somewhere between 10 and 20. This was 35. He hadn't had a stroke. He was toxic on dilantin. We stopped the dilantin. For a few days, we stopped the INH. And in a week, he was fine. But if we had not thought possible drug interaction here, he would have continued on and probably would have died of dilantin toxicity before he ever had a chance to die of anything else. So you need to think about these. They can be significant. You need to think about them when you start therapy. You need to think about them when you stop therapy. Because if we had that patient stabilized on both dilantin and his TB meds, and we suddenly stop the rifampin, his dilantin levels are going to change again. So you need to coordinate with private providers, whoever his private person is, who's prescribing those drugs. Sometimes you can switch to a different agent. Sometimes you could switch from dilantin to a drug like gabapentin, and the patient does well, and there's no interaction to be concerned about. Warfarin is another big one that we run into. Patients who are on anticoagulants. Rifampin will change the concentrations of your warfarin. You need to be aware of that. You need to be monitoring the patient. And if you're going to have to maintain them on both the warfarin and the TB drugs, you want to give daily therapy and not intermittent therapy. If you give intermittent therapy, their levels are going to be all over the place. Again, you could possibly switch them to a different agent. You could switch them perhaps to a low molecular weight heparin, something like Lovenox, for instance, or Rixtra. No interaction there, nothing to be concerned about other than the cost of those particular alternatives. Hormone-based contraceptives. This would be the patch. This would be the oral contraceptives. It could be the IUDs. Are going to be less effective with our patients on rifamycin. And there was a case a number of years ago here in South Florida, back when we didn't have any vaccines for H. flu and Neisseria meningitis. And there was a lot of cases of H. flu in daycare centers. So this woman's child was exposed to H. flu meningitis in the daycare center. Mother ended up being exposed. She went to a private physician who prescribed rifampin for her as prophylaxis. That physician knew that she was on oral contraceptives. That physician did not warn her to use an alternative method of birth control while she was on that drug and for at least the next cycle as well. She got pregnant. She sued the doctor. The doctor is paying to support that child. Now, 3 of us failed in that case. We failed the patient. The doctor failed because he didn't warn the patient. He should have known. The nurse failed because she didn't warn the patient. And the pharmacist failed because that person also knew that she was on oral contraceptives as well as rifampin. So we need to talk to our patients about these as well. We also know that there are drugs that have two-way interactions, efavirenz and the protease inhibitors that we use for HIV. Not only do the rifamycins affect the concentrations of those drugs can affect the concentrations of our rifamycins. So we need to be thinking about drug interactions when there's any change in the patient. So as our final question, which team is going to win the SEC championship? Florida Gators, Alabama Tide, or the what? We got too many whats out there. No football fans out there. Well, you're not in the SEC. Come on, Gators, go. Go, Gators, go. Yes. And with good reason, right? So this is what happens in my household. Maybe. This is Jennifer, and we're there waiting for the big football game to start, and we know the Gators are going to win. So if you have any questions, be sure to call in or email them or fax them. And if you have any other questions later on, the TV hotline number is 1-800-4TB-INFO. Thank you.
Jerry? Unbelievable. All right. That was Jerry. That was unbelievable. That was fantastic. Thank you very, very much. Before we start, I have an announcement to make that we're going to now open it up to questions, and Jerry Jean is going to help us out with answering those questions. Obviously, what I was going to ask is you have 2 different ways you can ask the question. The first is if you email it to us, we'd be more than happy to read it and go over it. But the other way, which we actually prefer, if you guys want, is call in on the number that's flashing on your screen now and tell the operator that you have a question, and then we can answer you live and we can have a discussion. So, Jerry, first of all, outstanding work. I mean, that was great. Hey, I'm going to take the privilege of asking the first question. Something you kind of touched upon, but I want to go over more. When we talk about drug interactions, I think the biggest drug interaction we see in TB here, at least in Florida, is alcohol. Now I know that's not a prescribed drug. I don't think it's well, it might be. Right, maybe. But I was going to ask you, so how does alcohol affect? How does it fall into this whole situation?
Well, alcohol can certainly affect the P450 enzyme system. So you've got a drug interaction there because you're increasing the metabolism of other agents. The real question for TB drugs is whether or not that ability of rifampin actually overwhelms the alcohol. But alcohol certainly has the ability of lowering our TB drug levels, primarily INH and rifampin, because of the increased metabolism. And we also have the issue of what happens to the stomach and, increased risk of hepatitis, increased risk of gastritis, and peripheral neuropathies in those patients.
I mean, I just have the interest, it's kind of interesting. In the state of Florida, actually, the laws actually state that if you're taking TB drugs, that you could not, you should not or cannot drink alcohol for these very reasons.
Right.
I mean, have you ever seen, do you think, well, at least let me ask it different, do you think alcohol actually interferes with TB treatment in some patients?
Absolutely. They're certainly more likely to be non-compliant, if nothing else, and it is an explanation for low levels in some patients.
I think it's one of our more common
Right. If they continue drinking, the hepatitis may interrupt our TB therapy. We may not be able to cure that patient.
Right. Any questions in our audience? First of all, I'm saying our live audience. Do you guys have a question by any chance? Please, Dee, hold on 1 second. Dee, go ahead.
Before you take that, could you have the operator tell them how to make the call?
I most certainly will. Thank you very much, Donna. Actually, before we take the question, if I can ask the operator to please explain to our callers how to ask a question, please go ahead.
Thank you. Ladies and gentlemen, if you would like to register a question on the phone lines, please press the 1 followed by the 4 on your telephone. You will hear a 3-tone prompt to acknowledge your request. Your line will then be briefly accessed from the conference to obtain information. If your question has already been answered and you would like to withdraw your registration, please press the 1 followed by the 3. And if you're using a speakerphone, please lift your handsets before entering your request. Once again, that's the 1 followed by the 4. I will now turn the call back to David Ashkin for questions from the web.
Thank you, operator. Dee, I think you have a question. Please, go ahead.
Yes, I do. In the case of clients who are experiencing renal failure, who have not yet started on dialysis, we have a client who has been diagnosed with HIV nephropathy. And as you know, renal clearances can change over time. Is it appropriate to do drug levels in those clients when they are also being treated for TB? And how frequently should that be monitored?
The area that I get most calls about are patients with renal insufficiencies and how to dose those medications. I definitely recommend that that's at least one class of patients where you need to do those drug levels because it is going to change, particularly a patient who changes over time or is rapidly bouncing back and forth. You need to be doing those levels fairly often. The patients on dialysis, you can usually use daily doses given 3 times a day after dialysis, and that will work. But again, there you also need to monitor drug levels because different filters, different solutions, different centers will remove varying amounts of the drugs. But absolutely, that is a population where you would want to do drug levels, and you need to do at least one after you adjust the dosage, and you probably need to do follow-ups in a couple of months. Well, it depends on the drugs you're using, but basically you probably want the patient on a stable dose for about 3 weeks, 2 to 3 weeks before you try doing drug levels. You want to reach steady state so you know where the patient's going to be. If you do it too soon, you may have too low of a level that's not realistic, but timing is really important on those levels is when you draw them as compared to when they gave the medication.
Jerry, actually, we have a question from the web. Ann Scapita is asking, in a related question to renal failure, she's saying that in renal failure, when you're modifying medications to lower doses or less times in a week, are we possibly building a more resistant germ? And to just go on, and then the second is it better to dialyze and give full medical doses? And then she has the reason she's saying she asked this is because they have an MDR patient who has chronic renal failure and is still infectious after 18 months. According to consultants that they've called on, says the National TB Center's guidance, he's on appropriate regimens after reviewing all of his test results. The only thing is that he's getting lower doses and less times a week for the renal clearing due to creatinine levels. So the concern is that they're not curing him and they may be building resistance. The question is, should they dialyze? And so I guess, how would you answer that question?
Well, I think in the first place, you definitely need to do drug levels and see where you're at. But it depends on the drug. If you're giving an aminoglycoside, if you're giving quinolone, you probably want to decrease the frequency rather than the dose. And because you want to get that peak, you want to get high enough above. But if you're looking at other drugs, just lowering the dose per day. But you would want to do those levels to make sure you're maintaining them for the duration. If you're going to give them less often, remember that if we give, INH has a half-life of 1 to 4 hours. So if you figure 5 half-hours half-life for INH, 20 hours, less than a day, all the drugs out of the system anyway. So if we're dosing twice a week or 3 times a week, all the medication is out of the system for 1 to 2 days in between as well. So that's probably not the issue. The issue is how high you are getting your initial dose.
You know, Jerry, is it concerning to you that they're still contagious after 18 months?
Absolutely.
And I think you'd agree, Jerry. I mean, the way we look at this is there's only really 4 reasons why people fail. You know, number 1 is always non-adherence. You know, the question, I guess, we'll go into a second is how do you monitor that? But the second thing is, you know, failure to, you know, absorb medications or at least get the expected levels. The third is that the patient may be actually developing more resistance.
Right.
And the last is the rarest, as you said, is they have a thicker wall cavity. And I think the answer is, in my opinion, and I'm wondering how you feel, to at least non-adherence and lower than expected levels involves, you know, doing drug levels. And I guess my concern is we're not hearing about drug levels here. Do you agree with that? I mean, I think...
Yeah, I think we definitely need to do drug levels on these patients. You never rule out noncompliance. You've got a patient who has renal insufficiency. They're nauseous a lot. So throwing up could be an issue. And when you throw up could be important. For instance, if you give the medication, you're giving INH and rifampin, say, and you give the medication and they throw up immediately, you probably did no harm as far as developing resistance because the patient didn't get any of the drug. If the patient doesn't throw up until 6 hours after you give the medication, you're probably not doing any harm to as far as resistance development because all the drug is out of the stomach by then. They're not throwing it up. It's been absorbed. It's a patient that throws up an hour after you give the medication that runs the risk of resistance because in 1 hour, INH is completely absorbed, rifampin is not. So you've got low levels of rifampin and you've got INH monotherapy, and you're going to develop resistance to INH, if not both drugs in those cases.
Well, we're talking about, you know, just, and then but as far as compliance, you know, we talk about drug levels. What's the role? You see, one of the problems with drug levels, in my opinion, is if the person knows you're going to do the drug levels, they take the meds. And the problem with drug levels, they only reflect what happens in that point in time, meaning for that day. So how do you overcome that? Because if I'm not taking drugs Monday through Thursday, and I do a drug level and the person knows I'm going to do it on Friday, how do I know? So what do you do in those situations? How do you get around it?
Surprise levels. You don't tell anybody. You don't tell anybody that you're going to do. You suddenly show up and say, I'm going to take some blood 2 hours after you gave them their medication. You come back and see them. Here, if we're going to do surprise levels, and we have patients who are non-compliant here, even though we do our best to do DOT, we don't tell the nurses, we don't tell anybody that we're going to do the level. Nobody but the lab and I know. Even you don't know.
Well, I never know anything. I mean, so that goes without saying.
So we catch them after a normal medication pass, which is 10 o'clock. We try to catch them 2 hours later without telling them we're going to do that. Well, we find a surprising number of patients that way.
Ann was cool enough, and Ann knows the computer much better than us because she just gave us a follow-up while we're waiting. And thank you, Ann, first of all. But she says the follow-up, he's getting DOT, but here's the thing. He's getting drug levels, and one level just came back as 0, 0.
Yeah.
So, like we've talked about, that's usually how they fail. And Ann, thank you. I mean, because it's a great case that you were sharing with us. That's where, like, you can't swear compliance and where drug levels come in really, really handy.
Right.
And then her next question is, can the patient come to A.G. Holly? We can talk about that right after that. We'd love to. Hey, Elena, you have a question, right?
I think it's on. Okay, real quick. Usually the doses of the TB meds, most of them are daily, the most common ones we use. Some of the second lines are more. Sometimes we see patients on divided doses, especially sometimes if the clinician feels that the GI intolerance may be because of the whole dose and divide it up. Can you comment on the efficacy?
Well, example that would be Ethambutol. Well, the patient's on 1,200 milligrams, so you end up giving 400 milligrams 3 times a day. Unfortunately, we've had patients come in with hospitals that have been on that type of a regimen, where And for someone who doesn't work in TB, sometimes the literature is confusing because it will say 1,200 milligrams a day, but it doesn't tell you whether that's a single dose or if it's divided doses. If it comes in 400 milligrams, then say, well, it's probably a divided dose, so we're going to give it 3 times a day. Problem is you never get high enough concentrations. You're constantly metabolizing it, so you never reach a high enough level of the drug to be effective. So you don't want to do that. You want to give it once a day. Now, drugs like ethionamide or PAS, you really have no choice because of the toxicities. So those you end up having to give more frequently.
Jerry, we got another question. Thanks, Elena. Hey, we got another question from the web here, and it says, this is from Virginia Dowell. Virginia, thank you so much for asking the question. She says, when you said someone that has problems with hepatitis, twice-weekly dosing could be considered. What about the doses of INH and PZA? Should be calculated at twice-weekly dosing or kept at the daily dosing recommendation?
Yeah, as long as they have normal function, I would do it at usual twice-weekly dosing. I would not reduce the dose of those drugs. You're just giving it less frequently so the body has more time to recover in between.
And Jerry, while we're asking that question, as you're talking about hepatitis, one of my pet peeves actually is that automatically somebody develops hepatitis, and automatically we automatically blame it on the drugs,
Right.
And I like to blame you for anything that goes wrong with the drugs.
Thank you very much.
It's usually your fault, But Jerry, is there anything else you should do before, before you blame it on the drugs? I mean, should you be looking for something else, or
Absolutely. Does the patient have a history of drinking? Are they drinking while you're doing it? Does the patient have a history of hepatitis B or C? Because it could be a flare-up of those things. And you certainly don't want to stop the TB drugs. You don't want to stop using our best drugs, INH and rifampin, because you think it may be causing it when actually they have nothing to do with it. Treat the underlying problem and continue your therapy.
And I think it could be also things like gallbladder, especially in women.
Right.
We always want to do a sono first to make sure the person doesn't have, unfortunately,
Right.
tumor or some other cause. And just like you said, the other thing is, as far as alcohol, which again, as you're hearing my bias, we see a lot of it, like some clues that the hepatitis could be secondary to alcohol and another drug is when the AST to ALT ratio is more than 2 to 1.
Correct.
Meaning that normally, if I'm correct, Jerry, that when the normal hepatitis that's usually from INH or rifampin, usually the ALT and AST will rise relatively to the same extent.
Correct.
But when you see that 2 to 1 ratio, that's usually a tip-off.
That's a tip-off that it's substance related, but you don't know if it's alcohol, if you don't know if it's the drugs.
Right, I totally agree. Hey, on that same basis of intermittent therapy, we have a question here from Melda. And Melda Dolorosa is saying that if the patient's on 3 times a week rifabutin, when do you check the drug levels? And is it the same as taking a daily dose of the med?
It is as effective as taking a daily dose, and you would do your drug levels at 2 hours or 3 hours, preferably with rifabutin. It's a 3-hour peak, 3 hours and 6 hours after the medication is given. On the days that they take the medication, you would do the levels. Now, rifabutin has a long half-life, so it's going to hang around probably until your next dose, but 3 hours and 6 hours after you give the dose. But it is as effective 3 times a week as it is daily.
And you do the drug level, as you're saying, either like, let's say you're getting it Monday, Wednesday, and Friday, you would try to do it on
Monday,
Wednesday,
or Friday.
Right, not in between. Do we have any questions in the audience? Please. Wait. I'm sorry, give me just 1 second.
Pregnant patient with toxemia, what do you do in that case?
I'm sorry, say what?
Person having intractable vomiting and all in pregnancy?
In pregnancy?
In a patient who's pregnant, you're saying, what do you do if you have, like, you said toxemia, but I think you're saying intractable vomiting. Is that correct?
Yes.
Okay.
Well, in fact, you're probably going to have to look at a drug to treat the nausea and vomiting. And I gave you several choices of things to try. You want to start out with the easiest things first. But you might have to go to non-oral routes of administering the medication. You may not be able to give it orally. You may have to go to IV therapy in those patients. Suppositories, yes, Elena, is a consideration in those patients, but there again, we don't know how consistent the absorption of the drugs is. And you would certainly want to do drug levels in any case in that patient.
We got a couple of questions here on the web that both relate to the interactions of Depo-Provera with the TB meds. And essentially, the question is, to what, Ann Rickard and Amy Burgess are both asking, to what extent does rifampin reduce the Depo-Provera levels, and also, the other question, how do they interfere with the action, and what should you do in those kind of cases?
Okay, the rifampin and mifebutin both will lower the levels. Mifebutin to a lesser degree than will rifampin. Mifebutin has about 1/3 of the activity on the P450 system, so that's about 1/3 of the potency of interaction as this rifampin. But rifampin will decrease. Depo-Provera is given an injection every 3 months. It will lower the level, and it will decrease the amount of time that the drug has effective concentration. So you may need to give it at 2 months or 2.5 months rather than waiting 90 days to give the next dose.
Very good. Ann Scarpita, sorry, I know you had a second question. Unfortunately, on my computer, it just actually eliminated that second question. So if you would be kind enough to send it back to us, I'm sorry about that, as it proves once again that I'm not good with computers. Any questions in the audience? Oh, I actually have another question. If it's okay, Jerry, for a second. It's, I guess one of the things we talked about is quickly using, drug levels for compliance. What's the role of, urine testing? As far as a lot of people used to talk about using a dipstick, the urine for, INH, and do you see that, or what's the problem with that?
Well, the dipstick is not going to tell you the results from today. It may tell you the results from yesterday, and it's not going to tell you the concentration in the blood. It will tell you whether or not the patient's taking the drug.
Yes.
But it's not going to tell you whether or not they're getting adequate or too high concentrations in the serum. So it's a good indicator. Drug levels are an expensive way to do compliance checks on patients. So that is an alternative for those. Uric acid, can be also used. If the patient's on PCA and the uric acid concentration is normal, they're not taking the PCA.
Right, I agree. And also, if I'm correct, the Thiamidol also causes a mild increase in uric acid.
Thiamidol can also do it, but I'd say that's probably less reliable than the PCA.
Yeah, and, one of the other things that we see from time to time that can be potentially extremely dangerous, we talk about, things with problems why drugs fail. But, one of the big problems is some of the drugs sound very much alike. And I know we've seen before, cyclosporin being prescribed instead of cyclosporin with extreme, extremely adverse effects. I think it's very important, right, especially in drugs that we don't use a lot, to make sure, especially by people, that we're making sure we're prescribing the right drug.
Yeah, it's easy to make a mistake between ethambutol and ethianamide would be another one where we've seen some errors made. So definitely know what drug you're prescribing and you're doing the right drug at the right dose.
All right. And any questions in the audience, in the live audience? Okay. I have one, last question, because you mentioned the case with the nurse that we had, and we talked about, that with her, what she did with the PEG and with the IVs. And Jerry, I'm sorry to say that I'm here to confirm your story. But, one of the things that we really didn't talk about in her, something that I think is important also why drugs fail, is the eating disorder.
Right.
And what made her very, very difficult is she had both anorexia nervosa and bulimia. So she actually believed, if you remember, that the medications were giving her calories, and despite us constantly telling her that there was no calories in the pill, she wouldn't take it. As a matter of fact, one of the things we had to do is we could, one of the ways we follow TB patients is by weighing them. We could not even weigh her in front of her. We had to turn her back, because if she knew she was gaining weight, she would actually not want to take the medications anymore. What is your experience with eating disorders, and who should you suspect? Who do you suspect has an eating disorder, or can you suspect it?
Eating disorder depends on the type of eating disorder, but in general, are their electrolytes normal? What is their acid-base balance? But are they exceptionally thin? Well, TB makes you thin too, so that's not always a good indicator. So what is past history? The patients that have eating disorders are very difficult to work with. You may need to go to a professional in the mental health field to get their assistance to work with those patients, because they are really sneaky and they are determined. And of course, if we treat TB and the patient gets better, they're going to gain weight, and that's the last thing they want. So they don't have a good incentive there from their perception to take the medication. So we do things like PEGs. They're great. We had the patient would take the medication orally, be walking down the hall with the nurse, turn her head and spit out the pills. They are really good at this sort of stuff. And often it's another patient that will tell you that that patient is throwing it up. And that's the patient's most likely to get resistance because vomiting is one of their ways of getting rid of the medications.
And I think you'd agree, what makes them very challenging is that the problem comes down to is that they're also at increased risk of getting TB because they usually are so malnourished that they become lymphopenic, from their protein malnourished. So the first thing is that they're at increased risk, so they're more, we're not thinking about it commonly. The other thing that, that I think becomes, challenging is that their mortality just from bulimia and anorexia alone is very high. Up to 25% of these patients die. And we've had a couple of cases here at Holly where, despite being watched and everything else, have done extremely poorly. I mean, and they're very challenging. I think Dr. Ortiz, Jesus, who's the head of our behavioral medicine, wants to comment on that. Is that correct? Go ahead.
Yes. You were asking how do you tell if somebody has bulimia or anorexia nervosa or some sort of eating disorder? Well, one critical aspect, they have to be obsessed with weight issues. So if they don't have that obsession, more likely they don't have it. And also, you generally don't have a history of that kind of behavior. So you can talk to family or people that know them, and they will give you information on it. But because it's unlikely that it's just developing right when they get admitted here.
Actually, the 3 cases we've seen, though, I believe, except for the nurse, the other 2, I'm thinking offhand of the last 3, at least in my head, I think only 1 had the diagnosis. The other 2 actually were made here. Actually, you were instrumental in at least one of them, picking it up on, at least for us, saying, hey, I think you got a problem here, and it's usually the staff of the other patients, as Jerry said, that really tips you off. Do you agree with that? I mean,
yeah, but generally there'll be a history of them having issues with their weight and like getting on the scales a lot and just overly obsessed with eating and the weight issue and their tremendous fear of gaining weight. So unless they have that, it's not really eating disorder. Then there's more maybe they're just sick from the medications and other issues. But that's one way to really distinguish, do the differential, see what you're dealing with.
Thanks, Casey. Thank you very much. Anne was kind enough. Anne Scarpita, you're the best. She was kind enough to
How much do we pay her?
Yeah, she's really desperate to ask you this question, or she's really trying to save me, which I think that was it. But she wrote, concerning a child who converted on a skin test from a contact investigation. The child's 3 years old. The child has 4 kicked, screamed. I don't think it has to be a child to do all that. I think could be a doctor or nurse. We'll talk about doctor and nurse, and has spit at the public health nurse. I mean, so right there, but, and while the DOT was being performed, and the parents finally refused during the initial treatment, it says that they know that the parents were actually splitting the doses and possibly not giving the second dose. And this is the question, is IMINH appropriate here, and so can they do DOT, and already, they've ruled out active disease in the child. So kind of very complex case, but something we've seen from time to time.
Right. Well, in a case like this where there may be a contact, the question is, do you need to treat? Well, a 3-year-old child is going to be at higher risk for going on to primary disease than an adult with that same situation. So you probably would want to do the INH prophylaxis if you can. What does the kid like to eat? Does the kid eat chocolate pudding? How about ice cream? How can you disguise it into something? Don't split the doses. And the big issue, I know of one case that I heard about that's sort of a horror story that's child very much like this. The health department actually put down a NG tube 3 times a week to give the kid medication. I think that's rather extreme. That's not someplace we want to go. A PET tube would be a consideration in this. You probably don't want to put them in the hospital and give them IVs, but, what can you find that child is going to take?
Yeah, I kind of agree with you. Because even if you think about it, even if the child is at increased risk, we're not talking 100%, it's still, you're talking about it, especially if there's no other concomitant illnesses. The chance of developing TB is still relatively rare, though it's something you want to prevent and easily preventable, and you really want to try everything possible to try to work with the child to find it. But in those severe cases, where we've had some cases, usually not over, infection, but if it really gets bad, you can involve child protective services in these cases if the parents are interfering with the treatment.
Right. Well, there's no indication here that the parents are really. So you certainly want the parents on your side when you're trying to do this. And, a suppository may be an alternative in a case
But
like
again,
that.
I think the most important thing, I think we'd all agree, is that these are really extreme issues, and
Right.
we'd rather not go that way. I think the best way is to try to find it, and that's where I think the pharmacist really plays a key role, because we would all look to the pharmacist to try to figure out how we can mix this and how we can get this into a form that's easiest for this child to take. I think we have another question in the audience. Dee?
Well, this isn't actually a question. It's a comment regarding the last call. I just wanted to say that one of our nurses had great success in helping the parents to train the children on how to take medication. And there are some real neat resources that address it, using M&Ms, that type of thing, teaching children how to swallow medication. So there are some resources available that can help to introduce the child to this process in a gentler way.
Yeah, I agree.
But it probably needs to be done earlier on rather than later on.
Okay, and we have one last question because we're running over time. Last question is actually from Anne Ricard, and she's asking, what interactions would you expect with street drugs?
Well, the problem with street drugs is you don't know what it is that they're taking. And just because they think they're taking one thing, that may not be at all what they're actually taking. I would be very highly suspicious if my TB drugs were having low levels. If I thought this person was using a lot of street drugs, I would probably want to do drug levels to see if there's an interaction. But we don't know because we don't know what they're taking. And there's not a lot of clinical trials out there to discover that information for us.
Jerry, and everybody, on behalf of everybody listening, Jerry, you did an outstanding job, and thank you so much for a great lecture. Jerry, I'm going to now give away your home phone. No. I would encourage that if anybody has any questions, if you call the hotline, the 1-800-4TB-INFO, and if you ask for Jerry, I'm sure you'd be more than happy to answer any questions.
Sure.
So, Jerry, I want to thank you once again for a great lecture. Thanks again.
Thank you.
I just want to remind everybody, we're going to be closing. I want to thank all of you for joining us for today, and thank you as always for making these the best. We really are interested in your feedback, so please remember to fill out the form so you can get your credit, but also to make these better. Include on there any programs or topics you'd like to see, and we'll do our best to try to bring them to you. Lastly, I want to remind everybody of some